We're going to have two individuals. We're going to have Shelley Roulard, Director of Department of Managed Healthcare, and we're going to have Janice Rocco, Deputy Commissioner, Health Policy and Reform, Department of Insurance. And we're going to have both come up. We'll start off with Ms. Roulard. Director Roulard, good afternoon, welcome, and please proceed.
Thank you, Senator Hernandez and committee members. I appreciate the opportunity to talk to you today. I'm Shelley Roulard, the Director of the Department of Managed Healthcare. Let me just start by saying that my heart goes out to the family of Barbara Reagan and the experience that they've been through, as well as Ms. Wenzel and what she and her family have gone through. I mean, in this day and age, we should not be having these kinds of stories to have to experience. So I just want to, and I'll be sharing with you some of the things the department is doing to oversee the plans and address mental health parity issues. But I just wanted to say that it's a very sad and tragic situation. So let's see. I do want to also mention that for other families who may be facing these kinds of situations where they are not getting care that they need, that we do have a help center at the department, and that is available to help folks who aren't getting timely access to care, who are having difficulty getting in to see their providers, whether they're doctors or mental health providers or whoever. And I'm happy to talk with them after the hearing, and I have some staff here who can give the phone number for the help center, or they can go on our website at dmhc.ca.gov. We don't get that many calls around mental health issues and access at the Help Center, frankly. We know that there's a lot more challenges going out there than what we're aware of, so the more information that we can get about the problems that people are facing, the more, the better able we are to take action to address them. So the department's mission is to protect consumers' healthcare rights and ensure a stable healthcare delivery system. Of course, mental health services are a critical part of the overall health system, and my department plays a pivotal role in holding health plans accountable for providing mental health benefits in a way that's on par with both medical and surgical benefits, and for having an adequate network of providers to do so. So in 2015, approximately 11% of the requests that we've gotten for independent medical review, 11%, and 5% of the complaints received by the department's help center relate to mental health services. So as I said, very small percentages. The complaints typically involve coverage disputes for services such as residential treatment and acute inpatient care facility admissions, as well as rehabilitation and counseling services. We take these complaints very seriously and work with enrollees to resolve the problems that they're having with their plans. Again, our mission is to protect consumers' healthcare rights. The department is also working with Kaiser to correct the deficiencies in its provision of mental health services that were identified in the 2013 routine survey the department did. And just for your edification, a routine survey is a comprehensive evaluation of the health plan's delivery system. State law requires our department to conduct a routine survey every 3 years for each licensed full-service and specialty health plan. That would include mental health plans, at least once every 3 years. During the 2013 survey, the department identified 4 deficiencies that limited enrollee access to care at Kaiser. This resulted in the $4 million fine, which was already spoken about, which Kaiser paid in September of 2014. The department then conducted a follow-up survey to determine if Kaiser had corrected the deficiencies and is complying with the law. In February this year, we released the report to the follow-up survey, which found that 2 of the 4 identified deficiencies had not been corrected. One is that Kaiser does not ensure that effective action is taken to improve care where access issues are identified, and that Kaiser providers relayed inaccurate and misleading information to enrollees regarding the scope of behavioral health services that are available. Although Kaiser has taken substantial steps to identify and monitor the issues related to timely access to behavioral health services, we have significant concerns that still remain. Their actions have not yet been sufficient to ensure enrollees have consistent, timely access to behavioral health services. Our goal for Kaiser is to correct the deficiencies and ensure that its enrollees have consistent and timely access to behavioral health services. The 2 uncorrected deficiencies have been referred to our Office of Enforcement, which are being further investigated. I will say that Kaiser is cooperating with us in that investigation, but our next routine survey of Kaiser, which will include both medical and behavioral health services, is scheduled for early next year. The issues uncovered in the department's survey of Kaiser's behavioral health services are distinct from the issues related to mental health parity compliance. The focus of federal mental health parity is on cost sharing and other financial metrics and whether they're applied similarly to medical services and as they are to mental health services within the same general service categories such as outpatient or inpatient treatment. The focus of the Kaiser survey was on whether enrollees were able to get timely access to medically necessary services within the regulatory timeframes. And although both of these regulatory activities look at mental health services, the specific areas of focus are very different. So the rest of my testimony today is going to be focused on what the department is doing with respect to compliance efforts around mental health parity and access to care through adequate networks. So I'm going to start with what we're doing around the issue of parity. The Knox-Keene Healthcare Service Plan Act of 1975 is the body of California law that governs the operations of healthcare service plans. That act gives the department the jurisdiction to license and regulate healthcare service plans, and in 1999 it was amended to include a mental health parity provision requiring that all plans that offer medical and surgical benefits to also cover the diagnosis and treatment of serious mental disorders in children and severe mental illness in patients of all ages. That law required that plans cover treatment for these mental illnesses on the same terms and conditions as they do for coverage of medical and surgical treatment. And in 2011, SB 946 enacted specific coverage requirements with respect to behavioral health treatments for persons with pervasive developmental disorder or autism. In addition to these laws, the Federal Affordable Care Act greatly expanded the scope of required coverage in California for individual and small group plans as a result of the Standardized Essential Health Benefits, or EHB. The EHB are all benefits that are offered through the benchmark plan, which the legislature has set as the Kaiser Small Group HMO 30 plan. The designation of this plan as the benchmark in California has made mental health and substance use disorder coverage much more robust because now plans must cover the diagnosis and treatment of all mental disorders in the DSM-IV, as well as treatment for chemical dependencies, which previously was not required under the Knox-Keene Act. The department's EHB regulation itemizes many types of inpatient and outpatient treatment for both mental health and substance use disorders that previously was not included in state law. The department works to ensure that health plans comply with these requirements through our licensing, survey, and complaint resolution processes, which I will discuss a little bit later. And since 2008, the department's been working toward ensuring compliance with federal mental health parity laws after the Paul Wellstone and Pete Dominici Mental Health Parity and Addiction Equity Act, which we call MAPIA, was enacted. MAPIA requires healthcare service plans that offer coverage for mental health or substance use disorders to provide the same level of benefits as they do for general medical treatment. The federal mental health parity law is distinguished from state law because it does not mandate coverage for specific mental health conditions, but instead requires that the way that mental health benefits are offered be on par with the way that medical and surgical benefits are offered. Because of the many inherent differences between mental health treatment methodologies and treatment for physical conditions, comparing the two types of benefits based on this standard is very difficult, complicated, and extremely detail-oriented. In the several years following the enactment of MAPIA, the department reviewed all of the plan's evidence of coverage documentation to determine if they were treating coverage for mental health services differently from medical and surgical coverage with respect to cost sharing and treatment limits. However, a complete compliance review was not possible until the federal government issued guidance on the methodology that states must use to compare mental health coverage with medical surgical coverage. That guidance came in November of 2013 when final rules were issued by the federal Departments of Treasury, Labor, and Health and Human Services. Following the release of these rules, the department developed a two-phase compliance plan. The first phase is comprehensive reviews of the plan's benefit designs and methodologies for providing mental health and substance use disorder services. And the second phase is on-site surveys of how the plans actually put those benefit designs and their policies into practice. So the first phase of our compliance review began in September last year of 2014 when 26 plans with commercial products submitted compliance documents to the department. We've been reviewing those and working with the plans to correct any identified deficiencies since then. Primarily, there are three major components that we look at. The first being financial requirements, which is basically the cost-sharing charge for mental health and substance use disorder services and how that compares to medical and surgical cost-sharing. We also look at quantitative treatment limits. These are things like limits on the number of days or visits for inpatient or outpatient services and whether they're the same or not for mental health and medical surgical benefits. And then there are the non-quantitative treatment limits, such as authorization rules, drug formulary designs, provider qualifications. In July this year, the department informed the plans that they must come into full compliance with MAPIA by January 1st, 2016, 3 weeks. All 26 plans have been evaluated for compliance in the 3 key parity indicators, and it's already resulted in plans having to make a variety of adjustments, including decreases in cost sharing for mental health and substance use disorder services, revisions in their policies and procedures related to prior authorizations and definitions of what is medically necessary, elimination of impermissible limits on services, and revisions to their evidence of coverage documents to more accurately describe the mental health and substance use disorder treatments available to enrollees. There are now 25 plans under the department's MAPIA review process because one plan has withdrawn from the market since the process began. Of the 25, the department has completed review of 10 plans, and their filings are now closed. As we indicated to the plans in the July 17th all-plan letter, they must be MAPIA-compliant cost sharing. They must have MAPIA-compliant cost sharing beginning January 1st. Although the department hasn't fully completed the review for the remaining 15 plans, all of those 15 plans have completed the portion of review that addresses cost sharing for mental health and substance use disorder services. So they are able to disclose to any changes in cost sharing for these services beginning in 2016. And I would say that in the vast majority of cases, the cost sharing has gone down significantly for mental health and substance use disorder services. Plans that aren't fully compliant by December 31st of this year will be referred to the Department's Office of Enforcement for further investigation and potential enforcement action. The second phase of our compliance review is targeted on-site surveys of all 25 health plans, which are scheduled to begin in April of 2016. They will be conducted by our Division of Plan Surveys, along with licensing staff and other key members of the Phase 1 compliance review. And after surveying the first 5 plans, the department will refine the methodology and make any necessary revisions to the survey tools. So our goal is to complete all 25 surveys by the end of the first quarter of 2017. So it'll take us a year to complete all those. And the findings for each of the surveys will be available approximately 6 months after the on-site portion of each plan survey is complete. So we expect that some survey results will be available on the department's public website by the end of next year. Let me just say that ensuring compliance with MAPIA has been extremely extensive and labor-intensive for both the plans and the department. California is setting a national standard for our review process, and the department has been asked by CMS for our insights and expertise as they move forward with their own MAPIA review. So I'd like to now move to describe the work the department does to ensure that plans have adequate networks of providers to provide mental health and substance use disorder services. All full-service and behavioral health plans are required to have contracts with mental health providers. Some full-service plans enter into a plan-to-plan contract with a standalone behavioral health plan to arrange for mental health services. This allows enrollees in the full-service plan to access the behavioral plan's provider network. For example, some of the larger plan-to-plan arrangements are Blue Shield, which contracts with Human Affairs International, a behavioral health plan, or United Healthcare that uses US Behavioral Health Plan. It's not uncommon for plan-to-plan arrangements to exist among plans with corporate relationships, such as the United Healthcare and US Behavioral Health. In other cases, plans may lease a mental health network from a provider group. In this scenario, the health plan is still responsible for arranging care for the enrollee, but utilizes the provider group's network and delegates some of its health plan functions to the group, such as claims payment or credentialing. For example, the health plan of San Joaquin and San Francisco Health Plan both contract with Beacon to use its network of mental health providers. In the case of such a delegation, the health plans still remain ultimate responsibility and risk for providing care to enrollees and must oversee the delivery of all plan services provided by the delegate. Some health plans directly contract with mental health providers. Blue Cross contracts with providers in the same way it contracts for physical health providers, generally through direct contracts with individual providers and provider groups. Kaiser has a similar arrangement, relying on its two exclusively contracted medical groups, the Permanente Medical Group and the Southern California Permanente Medical Group, to deliver healthcare services to Kaiser enrollees. These medical groups contract directly with mental health providers, who are the exclusive providers for Kaiser enrollees. And where the demand for services exceeds the supply of providers available through their directly contracted network, the Permanente medical groups have entered into agreements with Value Options, a separate standalone mental health provider network, to utilize their mental health providers through their organization. Also, recently, Kaiser submitted a filing to the department that the Permanente medical group has entered into a formal arrangement with Magellan Healthcare to provide supplemental outpatient behavioral health services. This proposed arrangement is currently under review by the department. The department also requires that plans demonstrate they have an adequate network of mental health providers. Under the law, an adequate network provides reasonable access to mental health providers and contains an appropriate array of provider types to ensure timely provision of all medically necessary services. So when we're assessing the plans, whether the plan's network is adequate, we first look to determine whether they have the following specific provider types: psychiatrists, psychologists, licensed marriage and family therapists, licensed clinical social workers, licensed professional clinical counselors, and qualified autism service providers, professionals, and paraprofessionals. When determining whether the plan has a sufficient number of providers, we first look at the types and numbers of mental health providers that actually practice and contract with plans in a service area. We access this information through our Timely Access database, the National Provider Identification Database, and other public sources. Then we examine the geographic accessibility of providers in the plan's network compared to the actual geographic availability of all practicing mental health providers in the region who contract with health plans. For example, we might compare the plan's geographic access report against geographic access reports run for all providers that are in our Timely Access database, or one of the other databases we use. This helps us understand whether a plan is failing to contract with providers in a particular geographic area or whether there are no providers to contract with it at all. Then we consider the typical enrollee utilization of different types of mental health providers. For example, enrollees typically visit psychiatrists less frequently than master's or PhD level non-physician practitioners because psychiatrists are more often involved in medication management, whereas non-physician practitioners typically deliver ongoing and regular psychotherapy. And finally, we assess the services that are within the scope of licensure for each of these provider types relative to the likely treatment needs of enrollees. So generally speaking, we look for a network to have, at a minimum, an adequate number of psychologists, psychologists, therapists, and qualified autism service providers to meet the needs of its enrollees. The other way we assess whether a plan has an adequate network is to look at the plan's annual Timely Access report. Plans must submit these reports by March 31st for the prior calendar year. The report is an overview and provides an overall assessment of the plan's abilities to meet the appointment wait time standards contained in our Timely Access regulation. And those standards are 10 days for a primary care provider, 15 days for a specialty care physician, 10 days for a non-physician mental health provider, and 15 days for non-urgent ancillary care for the diagnosis and treatment of an illness. And for urgent care, the regulation provides a 48-hour standard or 96 hours for when pre-authorization is required. Since the passage of SB 964 in 2014, the department now has the authority to require plans to use the department's standardized methodology to conduct surveys of provider wait times. Plans were required to use the standardized methodology to conduct surveys in 2015, this year, and will report the results as part of their annual reporting next March 2016. The department's 2015 standardized methodology added a specific requirement that plans report on appointment wait times for both psychiatrists and child psychiatrists. The department's Timely Access regulation includes additional requirements that apply to a plan's provision of covered services, including both medical and surgical, as well as mental health services. These include arranging for 24/7 telephone triage or screening services with waiting time not to exceed 30 minutes, ensuring that the wait time to speak to a customer service representative during normal business hours is not more than 10 minutes, coordinating with interpreter services in a manner that ensures provision of interpreter services at the time of the appointment, monitoring network compliance with the timely access appointment wait time standards and investigating and correcting deficiencies, and ensuring the plan has a sufficient contracted providers. But if a service area has a shortage of providers, we require the plan to arrange for enrollees to have access to contracted providers in neighboring service areas. The department's licensing and survey staff monitor compliance with the timely access requirements by reviewing these reports and taking action as appropriate, including potential enforcement action. In addition to the review of their annual reports, the department reviews the plan's timely access policies and procedures. We evaluate their operations through routine surveys and evaluate consumer reports received in the help center related to timely access. The timely access review is one part of the larger network adequacy standard review for mental health plans. So I know that's long and involved, but I want to thank you for the opportunity to share the important and hard work the department is doing to ensure that the health plans are providing the mental health and substance use disorder services that are required by both federal and state law. I have two of senior attorneys from our Office of Plan Licensing with me, Elizabeth Spring, who's led the mental health parity compliance activities, and Casey Cameron, our lead attorney in provider networks, and so they can help me answering your questions. Thank you.
Thank you very much. We're going to move to Janet. Did you have a question?
If it's your preference that we hold them to both?
Do you mind if we just do, yeah, if you don't mind, we just do both presenters and we'll ask questions. Yes, thank you, Senator. Janice Rocco, Deputy Commissioner, Health Policy and Reform, Department of Insurance. Welcome, and please proceed.
Thank you, Mr. Chairs and Senators. Thank you for the opportunity to be here at this hearing today to talk about these important issues. I want to echo the thanks that has been made earlier for the witnesses in the panel before us, Ms. Wenzel and the family of Barbara Reagan, for their important testimony here today. Mental health parity, including timely access to medically necessary health care services. Obviously, these are critical issues for millions of Californians, their families, and our community in general. The committee background materials provide information about state and federal mental health care laws, and as well, Director Roulard went through many of them. While some of the laws have been on the books for many years, including the state's mental health parity law, authored by Assemblywoman Helen Thompson, we have also seen the law strengthened recently, including by changes in the law brought by the Affordable Care Act and recent federal regulations that prevent cost sharing and service limitations for mental health and substance use disorder treatment from being more restrictive than for other healthcare services. Additionally, Commissioner Dave Jones strengthened the insurance code provider network adequacy regulations in January by issuing emergency regulations that went into effect immediately and are in the final stages of the rulemaking process right now. The department also issued emergency regulations a few years earlier specific to essential health benefits and another set of regulations specific to mental health parity that increased consumer protections. One of the areas of focus of today's hearing, obviously, is timely access to mental health care. Although the department receives a relatively small number of complaints from policyholders and medical providers about timely access to mental health care services, enforcement of the law in this area is obviously critical and in some instances can even help save lives. Commissioner Jones has made it a top priority to improve access to mental health care through the issuance of emergency regulations, through administrative actions against insurers that were out of compliance with the law, by filing amicus briefs and lawsuits supporting the positions taken by patients who were seeking care and were denied that care, and through the department's enforcement of new laws as they've come into effect. I'll talk about a few areas where the department is taking action that is based on some of those new laws coming into effect that provide additional consumer protections in terms of coverage requirements, mental health parity, and access to care. First, talking about network adequacy, the department's emergency regulations strengthen the network adequacy protections that had already been in place for many years. For example, the regulations include specific requirements for conditions that require frequent therapy, such as behavioral health treatment. As you know, ABA therapy is often required on a daily basis for many hours at a time. So in that type of a situation, clearly you would need more providers in the network than you might for some other conditions. The regulations also include new wait time and reporting requirements to help the department monitor whether or not patients are getting the care they need when they need it. The regulations include requirements that the provider directories are accurate and are updated on a weekly basis, which is now also in the state statute thanks to a bill by Senator Hernandez. And the regulations require that when the health insurer does not have adequate medical providers in its network in a particular geographic area, that the insurer arrange for out-of-network care at the in-network price. The department is reviewing the product filings and the networks for compliance in a number of areas. And what we find in doing those reviews is that it is not uncommon to then, require that the insurers add providers. We also do audits of some of the material that is submitted to us. In terms of the provider directories, sometimes it is very easy to see on its face without even going to the geo-access maps or other materials that are provided that a particular insurer clearly is not in compliance with the law. If you submit a document to the department indicating that, for instance, in the county of San Francisco, that you only have one ABA therapist, it is very hard to believe that you would be in compliance with the network adequacy laws. Other times we see things submitted that would indicate that a particular provider is providing services in 3 different counties in the state that are not geographically contiguous, that are very far apart, and we often then check to make sure, is that provider really providing services in those areas across the state on an ongoing basis, or is this outdated information? And generally it's outdated information. That means that the provider directory is inaccurate and needs to be corrected. We receive separate network adequacy reports for mental health and substance use disorder professionals and for qualified autism service providers so that we can ensure that those particular areas are in compliance with the law. Additionally, the Affordable Care Act has imposed a number of new requirements, and health insurers have been filing new products that must comply with all of the new ACA standards. Some of the kinds of things that we look at in reviewing these policies include ensuring that for all essential health benefits, that we are seeing that the mental health parity laws are being applied and taken seriously. One area worth mentioning in this regard is prior authorization for outpatient mental health services. While insurers may require prior authorization for some outpatient mental health services, they certainly can't require prior authorization for all mental health practitioner office visits because they don't do that for physical health. This rule also applies to mental health outpatient facilities as compared to outpatient facilities for physical illnesses. The prior authorization requirements have to be equivalent or they're not in compliance with the law and they have to be removed from the policy. We also look for equity and cost sharing between physician office visits and mental health care practitioner office visits. Evaluation of compliance with the recent mental health regulations is a complicated process, as the director mentioned earlier. In terms of the financial requirements, the cost sharing review, these are new legal requirements that have taken a great deal of time to make sure that we are enforcing them adequately. Beginning for the plan year 2016, the department requires carriers to submit a quantitative analysis demonstrating that the type and the amount of cost sharing applied to mental health services is equivalent to those for physical health services, the cost sharing being things like co-payments, co-insurance that the policyholder is responsible for. We also require plans to provide a narrative explanation of their methodology so that the department can verify that the analysis was done in compliance with the federal rules. The carriers must submit a quantitative analysis for each plan in a filing. The analysis must show the type and amount of cost sharing for each classification that meets the federal thresholds. So as was said, things like outpatient or inpatient or office visits, those types of classifications. We review the insurer's assignment of benefits to ensure the insurer used the same criteria and applied them consistently for the mental health services and for the other health services that the policy covers. The plan payment data is based on past claims history for the insurer, which means that once this analysis is done by the carrier, their cost sharing may end up looking different than one of their competitors, as would be required under the federal law. Carriers must also submit a narrative explanation of the methodology they're using and the standards and criteria that they use to assign the benefits for each classification. We review the methodology to ensure it complies with the law. So there's potentially quantitative treatment limits that we would see in some plans. And while the same process applies to quantitative treatment limits, we don't see a lot of them in non-grandfathered individual and small group policies. This is because of the benchmark plan, the EHB law doesn't really allow for that situation. However, when we encounter quantitative treatment limits in grandfathered plans or large group plans, we require the carrier to demonstrate that they pass the federal parity test by providing the kind of documentation I talked about, and that often results in the carrier removing the quantitative treatment limit from the large group plan or the grandfathered plan. In terms of non-quantitative treatment limitations, we review policies for things such as prior authorization or step therapy requirements for mental health visits to make sure that the standards there are not more stringent than for other physical health services. Again, plans that can't demonstrate parity have to remove the limitations in question. The parity issue that we see most commonly in the policy form review is the use of impermissible cost sharing in plan designs. We have a standard benefit plan design for the individual and small group market, but when you couple that with the new federal regulations, which you often end up with, the carrier does their calculation based upon their claims experience, and they end up needing to use co-insurance instead of a copay for a particular category of services. And then because of the standard plan design, what CDI does is says, if you have to use co-insurance, and the standard plan design asks for a copay, then you have to cap the co-insurance at that copay amount. And some of the carriers have told us that they have trouble with their IT systems in terms of accomplishing that, in which case we've told them, then you can't charge any type of co-insurance or copay to the person. You have to have the cost sharing be zero if your system can't accommodate compliance with the federal law in another method. In terms of prescription drug coverage, that is another area where we have asked the carriers to make a lot of changes, particularly in this last year. When you couple the essential health benefits requirements and the non-discrimination provisions, we have had to have carriers add prescription drug coverage, add particular prescriptions to their formularies, add more drugs at the 4 different cost-sharing tiers. In some instances, if everything is on the higher cost-sharing tier, moving some of it to the lower cost-sharing tiers. 2 of the conditions looked at for clinical appropriateness of drug coverage when we do this review are bipolar disorder and schizophrenia. We analyze the number of drugs available for the consumer to use for each of these conditions, as well as which drug tier it's placed on and whether prior authorization or step therapy are required. For each of these conditions, the insurer must cover an adequate number of drugs in each of the specified classes, which means that they've sometimes had to make changes to what they've submitted to the department. So it's not uncommon for us to require changes. So most of what I've been discussing so far are recent enforcement activities that have to do with getting the insurers into compliance with the newer laws. I would also say it's important to note, as with DMHC, we assist consumers who submit complaints to the department through our hotline or on our website, and we take complaints both from the policyholders, but also from medical providers who are assisting the policyholders. And the department conducts market conduct exams to look for problems that may not have come to our attention through the consumer complaints, or to look at some areas more closely where we have received complaints. The market conduct exams can then result in more targeted exams, which we've had to do, for instance, with autism. And so we look closely at those areas to figure out where the biggest changes need to take place. So thanks for including the department in this hearing, and I'll work with you in terms of answering questions and have one of our attorneys, Shireen Gadusi, here as well. Thank you.
Thank you very much. And Senator Mitchell, would you like to ask a question?